This is Michael Altos recording part 1 of Transfusion Medicine from Barish, Chapter 16. First, we're going to talk about the collection and storage of blood components. Often, whole blood is collected from donors. The whole blood is collected into bags, and citrate anticoagulant is added to those bags, and this is in order to bind the calcium ions in the blood and thus prevent coagulation of the sample. The blood is then centrifuged and the components can be separated into red blood cells, plasma, platelets, and cryoprecipitate. Other times, blood is collected through a process of apheresis. This is really a form of ex vivo centrifugation, where the blood is taken out of the patient, run through a centrifuge, and then the components that are not being collected are returned to the patient. There are various techniques that can be applied during the processing of blood components. One of the most common is leukoreduction, which means removing the white blood cells from the red blood cells or platelets. This process reduces the risk of causing HLA alloimmunization, and it can decrease the incidence of febrile reactions and the transmission of CMV. Leukoreduction may also reduce the accumulation of inflammatory mediators during storage in the blood bank. It may help prevent the transfusion-related acute lung injury. And some studies have shown that it decreases post-operative mortality during cardiac surgery. The United States is moving towards a 100% leukoreduction in the U.S. blood supply. Another simple way of processing blood cells is by saline washing them. This removes any excess plasma that may still be present in the packed red blood cells. And this may help prevent allergic reaction, especially in patients with IgA deficiency who are susceptible to allergic reactions. This washing is not sufficient to prevent graft versus host disease or HLA alloimmunization. Packed red cells can be irradiated, which just means exposing them to gamma irradiation. This will damage the DNA present in the white blood cells of the donor and can help prevent immune response against the tissues of the recipient. This would be the graft versus host disease. Many units are also tested for pathogens. This is most commonly done with nucleic acid testing, like PCR technique. However, inactivation of pathogens that are in the blood is not a technique commonly used in the United States. Products can be treated with solvent detergents, methylene blue or riboflavin, in order to bind and destroy various pathogens. But most of these techniques are not approved for use in the United States at this time. When red blood cells are stored, they can be stored in one of two common ways. The first is the CPDA technique. This stands for citrate phosphate dextrose adenine. And blood cells preserved under this technique usually have a hematocrit of 70 to 75%. The unit has about 250 milliliters, as well as a little bit of plasma, and has a 35-day shelf life when stored at 1 to 6 degrees Celsius. Sometimes a component called additive is included in the storage unit. These packed cells usually have a crit of 60%, have a slightly larger volume, and absolutely no plasma in them. They have a slightly longer shelf life of 42 days at 1 to 6 degrees centigrade. And some feel that these units have less incidence of transfusion-related lung injury, as well as faster regeneration of the 2,3-DPG, which breaks down during storage. As we just said, one of the most common metabolic changes is the depletion of 2,3-DPG, and as you know, this causes a left shift of the oxygen-hemoglobin dissociation curve. In general, as red blood cells are stored in the blood bank, the units become acidic, which leads to hemolysis of the blood cells and increased potassium. and actually about 15 to 20% of the red blood cells become non-viable during this process. There are those who believe that older units of blood may correlate with worse outcomes such as mortality and organ failure. Plasma, which is taken from whole blood, is also provided in units. A unit of plasma usually has 200 to 250 milliliters of volume. When it's collected using an apheresis technique, the units can be larger. There's some terminology we should go over. So when people talk about FFP, this has a specific definition, which is plasma that has been frozen within 6 to 8 hours of collection. And this is done because factors 5 and 8 break down very rapidly if the plasma is not frozen. There is something called FP24, which is simply when the plasma is frozen not within 6 to 8 hours, but rather within 24 hours of collection. And as you would expect, the content of factor 8 and to some degree factor 5 is going to be decreased. As we mentioned before, plasma can be treated with solvent detergent, which inactivates certain encapsulated viruses. This is especially done when pooled FFP is used for multiple donors in order to decrease the transmission of parvovirus B19. But this technique is not used in the United States. There are certain derivatives of plasma, including albumin, immunoglobulins, clotting factors, and other proteins. And these are separated by a fractionation and filtration technique, followed by ultrapurification. Just as a single point, a note that albumin is pasteurized at 60 degrees centigrade, so there shouldn't be any transmission of pathogens with albumin. We'll pause at this moment in case you have any questions that you'd like to jot down, and we can discuss them in class, or you can contact me by email or in some other way. Next, we're going to speak for a minute about the ABO typing system. Remember that blood comes in 4 different kinds of ABO classifications. It can be O, A, B, or AB. And the ABO grouping refers to the antigens that are present on that patient's red blood cells. So type O patients have no antigens of these ABO group. Patients with AB blood have the A and the B antigen, and obviously the A and B patients have only A or only B. So as a result, patients form antibodies against the antigens that are not present in their own normal blood cells. So the type O patients have no antigens and therefore have antibodies to both A and B, whereas patients who have AB blood and have both antigens have no antibodies, not to A or to B. Now that we've characterized the recipient red blood cells, we can identify compatible red blood cell donors. So obviously each blood group can accept red blood cells from its own blood type. In addition, they can accept blood cells from any donor whose antigens do not match the recipient's antibodies. So patients who have type O blood and have antibodies to A and B cannot accept A or B blood, whereas patients who have type AB blood and have no antibodies can accept red blood cells from all 4 blood groups. We also talk about whether blood is positive or negative. This is the rhesus or D antigen typing. Patients who have Rh positive blood carry the D antigens. This is about 85% of the population. And Rh negative patients have no D antigens, and therefore they carry the anti-D antibody instead. Unlike the ABO system, where patients automatically develop antibodies against those antigens that they do not carry, patients who are Rh negative only develop anti-D antibodies after they're exposed to Rh positive blood. And then subsequent exposure will cause them to have an acute hemolytic transfusion reaction, as we'll discuss later. This issue becomes very important when we deal with a woman who has Rh negative blood and her fetus has Rh positive blood, because there is a possibility that she becomes exposed to the fetal blood cells, and then she will develop maternal anti-D antibodies. When a woman has anti-D antibodies and her baby is Rh positive, this can lead to hemolytic disease of the newborn, as her antibodies attack the red blood cells of the fetus. We prevent this with RhoGAM, which is basically a D immune globulin injection. Next, we should discuss some of the basic orders that we send to the blood bank. The first is the type and screen, formerly known as the antibody screen. The purpose of this test is to identify the most common red blood cell antibodies that may or may not be present in a sample of blood that is being tested. The way this test is done is a sample of your patient's plasma is mixed with commercially prepared standardized red blood cells. We know that there are about 25 to 30 potentially hemolytic antigens, and we're looking to see if your patient's plasma will attack any of these antigens that might be present on a random donor in the blood bank. This test is basically an indirect Coombs test, and let's take a look and see exactly what that test is. An indirect Coombs test, as we said, takes the serum of the recipient, and the serum, as we know, contains the antibodies. This is then mixed together with some red blood cells from the donor. So we have donor blood cells and the recipient's antibodies. If there are any blood cells that have antigens which the recipient's antibodies would bind to, this forms an antibody-antigen complex. The last step in the indirect Coombs test is adding anti-human immunoglobulins, anti-human antibodies, which are called Coombs antibodies, and these antibodies will bridge between the recipient's antibodies, and we get this agglutination process, and that would be a positive test result. That would tell us that the recipient has antibodies against the blood cells of the donor. In this case, the donor would be a standardized sample, which would have a known specific antigen, and we would know that the recipient has antibodies against that antigen. And that's an indirect Coombs test. With a proper type and screen, the likelihood of missing a dangerous antibody is less than 1 in 10,000. And if patients are being transfused regularly, their type and screen should be repeated every 3 days in order to see if they've developed any new antibodies. In our intraoperative, perioperative setting, a type and screen should be ordered in cases where transfusion is not very likely, which means to say it's a possibility, but it's not likely enough to merit actually preparing a type and cross. In a normal blood bank, an ABO and RH type and screen should take about 45 minutes from receipt of the sample until blood can be released. The next step in this process is a type and cross, or a crossmatch. There are some centers that will only do what's called an electronic cross, which means if the patient has a normal type and screen, which does not show any antibodies to any of the common antigens, then blood will be released on the assumption that it only contains common antigens without worrying about any rare antigens. Some blood banks will do a very quick cross where they just do a 30-second spin and check it for gross agglutination, and that just is a spin between the recipient's plasma and the donor's blood. Other centers do a formal cross-match. This would certainly be indicated in a patient who has a known positive antibody screen or a history of having an antibody or other high-risk patients. A formal cross-match involves incubating the recipient plasma with the donor red cells and examining for agglutination, and this process takes about 20 minutes at most institutions. Statistically, a patient will develop an anti-red cell antibody every 1 in 200 exposures, once every 200 exposures. There are times when patients need emergency red blood cells, and we have a couple options when there isn't time to get a complete type and cross or even a type and screen. The first possibility is type-specific partially cross-matched or even uncross-matched blood. So this blood at least matches the patient's blood type. And this is appropriate in most patients. If the patient has not been pregnant and has not had a transfusion before, the chances that they have an anti-red cell antibody is very low. So the chances of giving them an incompatible unit when we use the type-specific partially cross-matched or uncross-matched blood is pretty low. In the worst case scenario, we can use group O red blood cells. People call for O negative blood, but of course if we know the patient has Rh positive blood, we can give them O positive blood. But this is really done when the patient's status is unknown. What happens after a patient has gotten a very large number of red blood cell transfusions? Well, the old thinking was after a couple units of red blood cells, the patient has developed a lot of new antibodies, and they really need a new type and screen before we can transfuse them based on their existing blood type. That's really old information. And the current information, which is reflected in modern textbooks, is that we don't have to worry about this until about 10 to 12 units of uncross-matched blood, about 1 blood volume. At that point, we don't switch back to type-specific blood until a new antibody screen can be done. Pause here in case you have any questions that you'd like to clarify, and then we'll move on to the next section of this video. Now we're going to start talking about indications for transfusion of red blood cells. This is a big question that continues to be debated right up until today in the literature and in meetings. We know that a unit of packed red blood cells normally increases the hematocrit by about 3%. That is, it increases hemoglobin by about 1 milligram per deciliter. The ASA recommends that transfusion of red blood cells is rarely indicated when the hemoglobin is above 10, and is almost always indicated when hemoglobin is below 6. But this is a pretty broad range. The TRICK trial, which looked at critically ill patients and compared outcomes with transfusion goals of 10 versus 7 grams per deciliter, found no difference in outcomes. And the TRACKS trial, which looked at post-cardiac surgery patients and set transfusion goals of 24 versus 30% for hematocrit, also found no difference in outcomes, and actually found that transfusion itself may be an independent risk factor for morbidity and mortality, even when you account for the fact that patients with lower hematocrits may have had more serious illness or more complicated surgeries. The Society of Thoracic Surgeons and the Society of Cardiovascular Anesthesiologists falls in line with what we've seen so far. They say that when hemoglobin is below 7, transfusion is definitely reasonable. And when it's above 7, transfusion should be done for patients who have critical non-cardiac end organ ischemia, or active blood loss, or clinical indication of tissue hypoxia, which might be measured by SVO2 or echocardiogram or ECG findings, or even oliguria. Certainly patients who have cerebrovascular disease or neurologic injury require adequate oxygen delivering capacity, and poor outcomes have been shown when hemoglobin goes below 9, but it's extremely unclear whether transfusion improves their outcome or in some cases may even worsen their outcome. So while a low hemoglobin is a bad sign of things to come, there's no evidence that correcting that hemoglobin makes things any better. Ultimately, we need to remember that the goal is oxygen delivery. Our goal is to keep supply above demand in all of the critical organs, in the heart, the brain, the kidneys, and so on. So the best thing we can do is try to adjust our supply and demand in every other way possible before we deal with the question of transfusing red blood cells. So remember, oxygen demand is based on things like hyperthermia, hyperthyroid conditions, sepsis, pregnancy, and oxygen supply can be limited in cases of low cardiac output due to coronary disease, sepsis, heart failure, as well as metabolic derangements like alkalosis, hypothermia, patients who have low or diseased hemoglobin, as well as patients with pulmonary disease or hemorrhage. I also want to point out that all of these guidelines assume that it's a euvolemic anemia. That means to say, if the hemoglobin is 10, perhaps transfusion isn't indicated, but if the hemoglobin is 10 and the patient is 4 liters under-resuscitated, then you may find that once you resuscitate them with 4 liters of saline, they no longer have a hemoglobin of 10, and suddenly they need resuscitation with blood. So remember that patients who have chronic anemia or acute hemorrhage should be resuscitated based on their euvolemic hematocrit after fluid resuscitation. Therapy should be guided by regular measurement of hemoglobin or hematocrit. And during acute hemorrhage, or if there's intraoperative bleeding or in a trauma situation, especially in a massive transfusion situation, sometimes you need to make a guess at what the future holds. And hemoglobin levels may still be normal or even misleadingly high because the patient hasn't redistributed yet, because their volume contracted, and if you know that bleeding will be ongoing, it may be prudent to set a higher transfusion goal. So for example, the British Committee for Standards in Hematology set a transfusion goal of keeping hematocrit above 8 during these situations. What are some of the body's normal responses to anemia? The first is to increase cardiac output. As we know, cardiac output is stroke volume times heart rate. It's also mean arterial pressure divided by systemic vascular resistance. So when a patient increases their heart rate and their stroke volume, this will allow more delivery of oxygen to tissues. And this is done as a result of low systemic vascular resistance, as blood becomes less and less viscous in the anemic state. Cardiac output actually does a very good job of auto-regulating over a very wide range of isovolemic hemodilution. So as long as you can maintain adequate volume status, cardiac output can do a very good job of maintaining adequate oxygen delivery, even in the anemic state. But during acute blood loss, when patients become hypovolemic, the vasoconstriction can significantly impair the ability of cardiac output to increase to meet oxygen demand requirements. Not only can the body increase cardiac output, but cardiac output can be redistributed to the most important organs like brain and heart, while sparing muscles, skin, and viscera, which may not need oxygen delivery as acutely. Coronary blood flow can be increased by up to 500% during the anemic state. And this is important because we've shown that reversible cognitive impairment starts to occur when hemoglobin goes below 7. And at this point, at least, it can still be reversible, but this is the time for cardiac output to be redistributed in order to maintain maximum delivery of oxygen to key tissues. Another technique that exists is increased oxygen extraction. The extraction ratio can increase from about 38% in average tissues to almost 60% as your SVO2 drops from 70 to less than 50%. One organ that is unable to do this is the heart. At baseline, the heart's extraction ratio is very high, anywhere between 55 and 70%, and the heart cannot improve upon this. So extraction ratio is primarily a technique used by other organs aside from the heart. This graph is here to remind us that your body also changes its oxygen hemoglobin affinity curve as a response to anemia. As hemoglobin drops to less than 9, the curve begins to shift to the right. This occurs not acutely, but rather over about 12 to 24 hours, and it's due partially to 2,3-DPG and partially due to acidosis. The result of this shift is an increase in P50, which improves release of oxygen. Remember that we said before, stored red blood cells have a depleted supply of 2,3-DPG. And so you can imagine that red blood cells that are older or that have been stored can actually have a left shift effect on this curve and decrease the ability to unload oxygen in the anemic state. Finally, the body is able to alter microcirculatory blood flow. And again, this is seen mostly in chronic, long-term anemias. This is based on the fact that as blood becomes less viscous, there's improved microcirculatory blood flow. Other changes along these lines include increased preload, which allows increased cardiac output, and this occurs due to capillary vasodilation, which improves venous return, and increased angiogenesis that occurs in the chronically anemic state. We will stop the recording at this point. Feel free to contact me with any questions, or please bring them to class for discussion, and we will continue with the next recording.